Welcome and thank you for joining us for the Charles R. Drew University of Medicine and Science Community Forum. Today's topic is COVID-19 and our community. The panelists for today are CDU President and CEO, David M. Carlisle, Paul Simon, Chief Science Officer at LA Community Department of Public Health, and Gail E. Wyatt, Distinguished Professor of Psychiatry and Biobehavioral Services at UCLA. The event is hosted by Sylvia Drew Ivie. Please welcome our guests and Ms. Ivie.
Good afternoon, everyone. Thank you so much for being with us today. I hope you're returning, or if you're new, welcome to our conversation about where we are with COVID and what is going on in our community about it. I opened my iPhone in preparation for this meeting just a few moments ago, and the headline on MedPage was over 50% of the US population have contracted COVID, according to the Centers for Disease Control, over 50%. With 1 million deaths thus far. So you may have been with us before. You may feel that you have learned a lot about COVID, but there's always more to learn. And we're going to try and do that today. We have distinguished panelists with our president of CDU, Dr. Carlisle, Dr. Gail Wyatt, who is an endowed chair and distinguished professor at UCLA, and Dr. Paul Simon, who has been our chief science officer at the Los Angeles County Department of Public Health for over 22 years. So we have people who care about you. We have people who are researching what's going on that puts your health and our collective health at risk. So it's a very important discussion that we're continuing to have. My name is Sylvia Drew Ivie, and I'm Special Assistant to Dr. Carlisle for Community Affairs. COVID continues to be a moving target. The rates continue to tick upward, but hospitalizations are not increasing. That's the good news. That's the only good news at the moment. It's getting warmer, and we're doing things like Riverside County is having 100,000 people a day gathering for a music festival over 2 weekends with no COVID policy in place whatsoever. So we've gone on with our lives, and yet we get this headline from CDC, over 50% of the population has had COVID. We've learned that COVID was the third leading cause of death last year, and it beat out only two other things that challenge us. One is heart disease, and the other is cancer. So think about COVID as being number 3. It's not just a random other infectious disease, it's number 3. Mask mandates are back in parts of the country and a thing in the past in other parts of the country. A 4th round of vaccines has been approved for parts of the population, while another portion of the population refuses to get vaccinated. They refuse based on ideology or personal hesitancy. And we're all collectively suffering a little in numbness from the news on COVID, because we've been at it now for a very long time, but we can't afford to be numb. So we're doing this every month. And we're so delighted to have these presenters today. You have, I think, the opportunity to look in detail about the background of our speakers today, but let me just share with you that Dr. Gail Wyatt is a person I have known for many years. In my youth, I worked on HIV issues with THC clinic, and Dr. Simon was involved and knew Gail Wyatt in that period of our advocacy. We thought that was the worst thing that ever happened, HIV, but we've learned that there are worse things. She is the Endowed Chair and Distinguished Professor of Psychiatry and Biobehavior Science at UCLA. She's the first African-American woman in the state of California to receive a license to practice psychology, and the first African-American woman to be named a full professor of the UCLA School of Medicine. So welcome, Dr. Wyatt. We have an equally distinguished panelist in Dr. Paul Simon, Chief Science Officer for us at the County Department of Public Health, which he joined in '98 as the Director of the Office of Health Assessment and Epidemiology. He served afterwards as the Director of the Division of Chronic Disease and Injury Prevention. His expertise in epidemiology made him a valuable asset in this battle that we're all engaged in against COVID. So thank you, Dr. Simon, for being with us. It's really wonderful to get a chance to introduce you to the CDU community and our supporters. So let me turn now to our third panelist, Dr. David Carlisle, who is here every time we have one of these forums. So you really know him a little, I hope, by now. He is our president and CEO of CDU. He's held that role since 2011. And he is a board certified internal medicine specialist. So we have two physicians in our panel today. He's a published author and served as director of the Office of Statewide Health Planning and Development for 11 years. Under three governors. Who were the three governors, Dr. Carlisle?
Governor Davis, Governor Schwarzenegger, and Governor Brown.
All right. That's probably a record for physicians in that position. He's been a champion in the fight against health inequities and a captain of our vision at CDU of a world without health disparities. Welcome back, Dr. Carlisle.
My pleasure. Thank you.
Thank you, those of you who are listening, for joining us for the first time or for returning today. For those of you who've been here before, this is our first time using Zoom. So with Zoom, you'll be able to type in your questions, and if we have time, we'll get to your questions at the end of the conversation. I'm going to start our questions with Dr. Wyatt. Dr. Wyatt, first, I'm going to ask you to define for us what biobehavioral science is and how can that be applied to our communities. That's an obscure title to the lay audience.
First of all, it's a pleasure to be here. It's a pleasure to be introduced by you, Sylvia. As you said, we've grown up and old together.
Oh, and young at heart.
Seasoned, right. I don't mind being old. I think it also says that I am a survivor.
Okay, all right.
And Dr. Simon, it's nice being on the program with you. It's always a pleasure to be on the program with Dr. Carlisle. So this is a great opportunity for me to talk about something that I'm asked about a lot when people hear that I'm in a department, psychiatry and biobehavioral science. It's, what's that, you know? Well, that's what we've been doing in our Center for Culture, Trauma, and Health Disparities. But a lot of people are engaging in biobehavioral science because it really is the way to look at the body and the whole person. When we talk about things you can see and things you can't see, about a person, that's what is incorporated in biobehavioral sciences. So we're not just looking at how the person thinks, feels that may affect their health and mental health. We're also looking at things you can't see, like blood pressure, like height and weight, and A1C, which assesses whether you have diabetes or not. A number of indices that are expressed in your body fluids that have as much to do with how healthy you are, how you tolerate stress, and what you need in your body to be even more well than you may be in biobehavioral sciences. The thing I like about it is I get an opportunity to look at people's mental health. I think mental health is something that we are really impacted by when it comes to COVID, because we can assume that it's been frightening, it's been confusing with all of the instructions and demands that have been placed on each person, each family, all the units that we belong to. But it's particularly challenging because COVID is something that is changing. We didn't know a lot about it. And this is what I think a lot of people are confused about. Whereas we've lived with heart disease and cancer for a long time, we don't know a lot about this particular variant. And we have to change what we've said and what we think, along with what we're continuing to learn. It may be confusing and frustrating for a lot of scientists who like to say something and they'd like people to believe they know it and it's not going to change. But in fact, we have to continually tell our audiences. Now, this is what I'm saying right now because it's based on what I've learned. In a month, I may know more. In fact, in a month, I may tell you that that's not necessarily true, what you heard me say last month. And this is the truth. And I think for that reason, our society is not used to hearing messages that change. They consider that to be confusion and being said by somebody who doesn't know. When it comes to COVID, we should expect that people will change their attitudes about it, the information that they provide, and they should be even better informed because we're learning. This is a learning process. And I think in our communities that have not always had good health, we've not always had health professionals that are well trained to understand our history of health and the lack of it in certain communities, and also the attitudes that apparently are quite difficult to change. And we need to develop a health literacy. And I think a health literacy means we understand what diseases are about. We know what has to change. We know what we need to do in order to stay healthy. And with COVID, we've been told at the very beginning, if you remember, don't touch certain things or be careful about wearing your gloves, all the way to now where people say you don't need to worry about gloves because we know that you don't really get COVID by touching certain things. It's the droplets that can make the difference between whether you become infected or not. It's things that you can't see that can infect you. Even in your families, it's things you can't see. It has nothing to do with whether you know people, whether you love them, whether they're kind to you. It has to do with our biology. So here we go with biobehavioral science. So if you're in a research project like any of my own, you should expect us to collect data on your blood. You should ask, why aren't you collecting data that will tell you how my body responds to diseases, what my immune system is able to do? Because if I need help with my immune system to fight off the severe effects of COVID, I need to know that. I need to know what I'm doing every day in my life that's making me more vulnerable to COVID than perhaps what I realize. And that's what we're teaching people now.
Thank you. Thank you. That was very helpful. Dr. Simon, you've worked with the County Department of Public Health, which has traditionally looked to address health disparities in our communities. And COVID has hit us differently in different communities. How has that influenced your efforts in the department?
Thank you, Sylvia. And first, I also want to just say thank you for the invitation to join both Dr. Wyatt and Dr. Carlisle today on this panel. Very much appreciate it. Yes, unfortunately, we face tremendous disparities in health across Los Angeles County, and we actually prefer to use the term inequities rather than disparities, because these disparities or differences are both unjust and they're also preventable. And unfortunately, we've seen a great worsening in these inequities during the COVID pandemic. You mentioned that the CDC has reported that COVID is now the third leading cause of death across the country. And I think that's a bit misleading. The CDC has been criticized because they lump all the different types of heart diseases and all the different types of cancer together, when in fact, those are all different diseases. You actually separate out the specific diseases, as we do in LA County and as we do across California. COVID has actually been the leading cause of death over the past 2 years, behind coronary heart disease, ahead of coronary heart disease, and also ahead of any of the specific types of cancer like lung cancer, breast cancer, colon cancer. So it's been obviously it's had a very significant impact on our communities. As I mentioned, the inequities have been really staggering. For example, we see that the mortality rate among people living in communities with the highest levels of poverty have 4 times the mortality rate as those living in communities with the least levels of poverty. We also see great differences across race and ethnic groups. We see big differences by age group. We see differences by gender. For example, while infection rates are similar for males and females, the mortality rate is actually quite higher for males than females. And so at the health department, we focus very much on trying to address these inequities. And just as Dr. Wyatt talked about the importance of both biology and behavior, we all also know that a lot of what drives these inequities are things that exist, conditions that exist within communities. For example, with regard to the COVID pandemic, the fact that we have so many people living with insecure housing, either living on the streets, 70,000 people across the county who are unhoused, or people living in crowded housing, low-wage workers that were working in incredibly unsafe conditions. Both the unsafe housing and unsafe work environments very much contributed to the inequities in COVID that we've seen across the county. So we've worked very hard as a health department, I think, to strengthen our relationships with community organizations, with labor organizations, with school officials, to try to create the safer conditions that will help ameliorate the impacts of COVID.
Well, I'm still reeling from your correction to the Centers for Disease Control on what the #1 cause of death is. That's pretty startling, that's going out across the whole nation, and you're saying it's misleading. It's a misleading statement.
I'm not the first to make that statement, but yeah, I think you can look at the leading causes of death in different ways.
Okay.
And I think we in California believe that we ought to look at these more specific causes.
Well, thank you. Thank you for that help in understanding that. Dr. Carlisle, it seems that the face mask policy has been a roller coaster. Some states and school districts have dropped the mask mandate, and some are returning to them. A judge invalidated the mask mandate for mass transit, so masking on planes is no longer required on some carriers. What's certain is over 2 years into the pandemic, nobody wants to really wear a mask. Nobody wants to. But what role do you think masks should be playing in our communities today? And has a potential for a cohesive masking strategy expired in face of our annoyance, our apathy, our lack of information about what's going on?
Well, thank you, Sylvia, and great to join my fellow panelists, as always, for this event, this community forum. Yes, I think that we're at a inflection point in terms of mask policy. And I hope that we continue to go in a direction where there's continued pressure to decrease mask usage, because it means that the pandemic is starting to ebb away a little bit. But I suspect that's not the case. I'm about to get on a plane and fly across the country tomorrow, and I will be wearing my face mask, despite the fact that I don't have to. And I'm probably going to be counting the number of people who are wearing them and the number of people who are not on the airplane. You know, you started out by referencing this Riverside Music Festival. This is the world famous, maybe the biggest outdoor music festival in the world, the Coachella Festival. And there have been thousands of photographs published online of people, mostly about what they're wearing or not at the festival. I can't think of a single photograph that I've seen out of that festival, out of the Coachella Festival, that shows anybody wearing a face mask. And I think this really says something. If you can have hundreds of thousands of people and nobody is wearing a face mask, despite the fact that we're still in the midst of the COVID-19 pandemic. So this is an issue. I would actually recommend that our audience look no further than at what doctors are doing right now. Because I think if there's anyone who has a good feel for where COVID-19 is and where it's headed right now, it's certainly the physicians. And of course, we have different perspectives, different opinions. But if you look at most of us when we're out and about in public, we're probably still wearing our face masks. And I certainly am when I go out in public, even though I don't have to. And I think that just reflects the concern that physicians have about COVID-19 and the fact that it is still with us.
Well, I don't know that the general public is hanging out with physicians that much, or PhDs that much. I think they're much more likely to be hanging out with their friends at school, or going to festivals. I don't think we have the right messengers. Gail, do we have the right messengers to what can we do about messaging this at this moment in time?
I think we need to take the time to do what we used to do, and that is get to know communities. And who are the community leaders? Who are the people that people listen to in a community? And they very frequently are not the people, maybe in the larger society. I like to talk about the deacons in the church, for instance. The deacons in a church, some of them are not even working. They don't have jobs, or they don't have high status jobs. But when it comes to that setting, they're looked up to for their belief or their commitment to the church, to God, to, things that are important to that system. Every community has leaders, and they may not be people that we know. We have to find out by talking to other people. But I really think the success of our being able to educate people in various communities of color that don't always have good health care is that we take the time, that the city, that the county takes the time to move out into communities, to do town halls, to do groups with masks, Dr. Carlisle, so that we get to know what are people thinking and feeling. It isn't enough just to have a television ad or an occasional ad, if you're in a large group setting, because at Coachella, you could wear a mask. It wasn't required, but you could wear one if you wanted to. And that says a lot, doesn't it? When most people don't want to, or they don't think it's cool. That's not really giving people in that setting the right message. I like to think of mask wearing as something that I personally have to do according to my own health. And it's like the rain. Somebody may think a couple of drops of rain is not a big deal for them. It is for me. And I know because of my health, and I don't like to get wet, I'm going to take care of myself, and I'm going to be prepared when I go out. If somebody says it might rain, I'm going to be ready for it. I think that what we fail to do when it gets to be a public health issue is explain to people, you have a personal responsibility, not just for yourself, but for those people around you. And that means you must not only protect yourself, but you have to protect those people who don't know, don't want to know, or they're too young or unable for some reason to care for themselves. And I think when we do that, we give a different kind of a context to how important it is that we look out for others. When we were growing up, and I was raised by Southern parents, we were told that was important. An important element of growing up was how caring and loving and attentive you were to somebody else, not just to yourself. And
Is that part of what public health does, Paul? Is that something that's outside the domain of keeping track of what's going on and keeping us informed of the data? I mean, who is in charge of saying it's your duty to do this for yourself and for others? It seems to me that's not part of the role of our academic or professional health leadership. Dr. Carlisle has been very successful at CDU, having a weekly meeting since the beginning of the pandemic. And I don't remember in any of those meetings, Dr. Carlisle telling people it's your job to protect others. I think he has said to us, it's your job to protect yourself, and this is what you need to protect yourself from. And hear the statistics on what's going on. I think it's quite a different thing to say you have to protect others. What am I thinking about that wrong, Dr. Simon?
No, I think you're right on. And in fact, we have tried to share those dual messages, both to protect yourself and to protect others. But I completely agree with what Dr. Carlisle and Dr. Wyatt were saying, that just as important as the message is the messenger. And frankly, I think there's a lot of distrust in government right now. And I could, walk into a community forum and provide very accurate information, but not necessarily sway anybody. Well, we try our best. We have invested much more than ever before, I think, in community organizations. We've been fortunate to get additional funding for COVID, not enough, but considerably more than what we had. And we've directed a lot of it out to community-based organizations because we feel that they know their communities best. Folks in the community that are uncertain or skeptical are much more likely to listen to their neighbors and their friends in communities. We've had a very successful collaboration with a network of faith-based organizations across the county. And while we haven't seen the vaccination rate, we've talked about masks, we haven't yet talked about vaccination, which is another important layer of protection. We have seen, I think, improved levels of vaccination among African Americans, Latinos, not where we'd like to be, particularly among young adults. But we feel like the partnership we've had with faith-based organizations has gotten us a lot further than we would have been if we were the ones, disseminating the messages.
Dr. Carlisle, is it possible with the numbers being greater now among young people than they are among older adults, that we could get to the message of duties to others, thinking about our youngsters? Might that be a new avenue of concern beyond self? And are we getting that message out about the fact that the young people are the ones that are most at risk? Because we've done a good job with the old folks getting the message out, and the statistics show that.
Sylvia, ironically, one of the differences between the pandemic in the US right now and what China is going through is the relatively low or lower vaccination rate among older people in China compared to the United States. That message, as you said, has gotten out in the United States, but it's not gotten out equally around the world. When I interact with young people, like students at our school, I know that our school has a special set of very special young people. I tend to encounter young people who are very caring and want to protect their friends and loved ones. And I think that using young people as messengers is a very important component of fighting the fight against COVID-19. If we want to extend our effectiveness I think that we could invest in finding ways to extend the use of our youth in addressing the COVID-19 pandemic as it converts from being pandemic into endemic, basically, which is, I think, what our future is going to be.
Dr. Wyatt, what are our vehicles for reaching young people? What mechanism do we have to launch a campaign for youth awareness and youth advocacy?
Well, I was thinking of concerts. Music is always a great way to bring people together, and sports are also great ways. And those are very easily translated into opportunities to talk about, things that concern all of us. But some of the tenets from social work, block clubs, remember block clubs? The people used to gather together and you had in your window that you were a member of the block club. Well, this was for safety. It was for prevention of crime, I think. But why can't we translate those old mechanisms into things where we can talk about strategies for COVID prevention, strategies for HIV prevention on a block level? And blocks can educate each other and have potluck where everybody brings something, but you sit down, once a week or twice, every 2 weeks, and talk about who needs what and how can we help each other. I think that's what public health is. You're not just concerned about yourself and what goes on in your home, because you can do all of that and still get infected. We all know that now, that you can be as vigilant as you want. But if everybody isn't, it doesn't matter. And I think this is one of the first times America has had to come to grips with what it means in a collectivist community, because this is a we issue, isn't it? Everybody has to get involved. You just can't say, well, no, I'm not interested, or this isn't for me. You can still infect people. So I think we've approached it from the wrong way, and we need to come back now and we need to say, we're listening. We want to increase vaccination rates. We want to increase testing rates, and we're going to try some different things. We're going to hire some different people that have different skills, and they may not be well educated, but if they speak well, if they're respected and they get the message and know how to carry it into the community, I think those are the job requirements that we need. And I think that the Drew School is a great place to develop programs with the support of the county, so that we begin to enlist different people helping us to increase the roles in our communities. We don't have a thing to lose except our lives. And I think that, for us to just continue and to denigrate those people who are not vaccinated is to say that we are impatient and we don't really understand how we've ignored people for as long as we have. We need something new.
Can I just add?
Yes,
we do have a student ambassador program. I completely agree, actually, that young people are more likely to be receptive to messages from other young people, and we've tried to take advantage of that. We would love to scale that program up to a greater degree. One of the challenges here is that Los Angeles County is just so big. The ambassador program has been successful, but not scaled to the level it needs to be. So we would be very excited about any partnerships with CDU or any of the listeners today to expand our program.
And that's
Great offer.
That sounds great.
Yeah.
I wonder also if there are any athletes that we could enlist, because young people listen to the athletes.
They do.
And
some of those appearances that athletes make, at an activity, people wait for that person to come so they can, have a minute to get an autograph or anything. I just think we need to go back to what we know attracts people to everyday events, and to take the fear out of it, but also to put in, this is something we have to learn to live with. I think Dr. Carlisle said that. So if we want it to be an epidemic and not a pandemic, then we have to bring it down to make sure that Los Angeles County, that the state of California, that the nation is really adapting public health strategies. And we're not talking about love of country. We're talking about love of each other. respect for each other and take the whole democracy and freedom out. That's the wrong message. We all love America, or we should. We're very privileged people, but our attitude about the opportunities to prevent this disease from killing other people and ourselves is really very sad. I have international programs in South Africa. They are begging to be vaccinated. They are begging for boosters. And here we are deciding not to take them. I don't get it. We need to do more to get down to where America can listen, and we need to listen.
Dr. Carlisle, homelessness has become a growing and apparent issue in our communities and seems to have accelerated during the pandemic. Is there a prescription for getting our arms around this problem while still facing down the pandemic, or is it just beyond our capacity? These ideas Dr. Wyatt and Dr. Simon is sharing, seem like there's much more to be done, but we can do it. We have some experience that we can use. But what do you do in the situation with homelessness and the spread of COVID among homeless individuals?
Yes, Sylvia, this is certainly one of the great scourges of our time. And I'm far from a homelessness policy expert, but I do know, and I'm quoting Dr. Father Andy Bale, who asked me one day, where do you think most of the people here at the Union Rescue Mission come from? And I said, I don't know. And he said, they come from South Los Angeles. And I think that that this is evidence of the fraying of the safety net of our society, the fabric of our society, that people are exposed to homelessness in ways that you don't see in any other industrialized nation around the world. I would ask the question, what is France doing to combat homelessness? What is Japan doing? What is Finland doing? What is Great Britain doing? What is Germany doing? Because they seem to be doing much better than we are. And of course, homelessness there is not the same as it is here. But they do have more effective policies. And I think that we need to start by taking a look around the world to see what's working around the world and how we can use those policies here. And you're right, COVID-19 has exacted a greatly disproportionate toll among homeless individuals. And this is because of all the risk factors that they bear, including lack of access to vaccination, lack of access to testing, and lack of access to all sorts of other preventive measures, even simple face masks. So this is an issue. But I note also that as COVID-19 deaths have increased among the homeless population, so too have overdose deaths. This is now probably, it's always been a facet of homelessness. It's always been an issue among the homeless population, but deaths due to overdose have skyrocketed just within the past several months here in Los Angeles County. It's made a already horrible problem even worse.
Go ahead.
I just thank you, Dr. Carlisle, for mentioning that. We just did release a report, an update. We've had 2 or 3 prior reports. This is the most recent trends in mortality among those experiencing homelessness. And the effect of the pandemic hasn't just been COVID mortality. As Dr. Carlisle mentioned, we've seen, unfortunately, a great acceleration of the increase in drug overdose deaths. We've seen an increase in heart disease mortality among the homeless. We've seen an increase in mortality related to violence and also traffic related injuries. All of those sort of, indirect adverse impacts of the pandemic. We've been so focused on trying to control the spread of this virus that unfortunately folks have not had the same level of access to services for many of these other important issues. So, it's clearly a major priority for us to try to get our arms around the homelessness problem in LA County. No simple answers. A lot of money has been invested, but not, I think, a clear, vision and implementation of that vision. A lot of, I think, politicization, unfortunately, of the issue. In the newspaper today, the executive director of the LA Homeless Services Authority announced that she's stepping down from the position. I don't know all the reasons why, but it really, I think, underscores the need for all of us to be on the same page here in coordinating our efforts to address this problem.
Well, it's unfair, I think, to expect one director of homeless policy to solve the problem. I think we've all got to work together
Absolutely.
to feel that we can do something and then to do something.
Sylvia, may I just add?
Yeah.
I think homelessness is really a very tragic example of how we have neglected mental health in our nation. There is no way that we're going to be able to solve this problem by constructing homes if we don't acknowledge that this is a very vulnerable population of people who needed help when they had a home and they weren't getting the kind of health and mental health care that they needed. They cannot understand, we can't understand the needs of homeless people if they do not have access to mental health care in the way that they wanted. They may not want to come into anybody's office. But again, if we break down areas into communities, small groups where people feel comfortable and they will come and sit and do groups, then we have a better chance of addressing the needs of the population. We can't dictate to homeless people. If you've talked to a homeless person who's been out there for a number of years, you can't tell them what to do. They will tell you what they're going to do, and they don't care if they are hungry, cold, neglected, abused, assaulted. You have to listen. And what you usually hear is, but I miss my family, or I wish I could see my granddaughter, or I wonder how so-and-so is doing. They have families, they have needs, they need to get reconnected, and they need mental health, better mental health services.
But let me just be devil's advocate and say, we don't do that for the housed population.
I know.
How are we going to?
How do you start?
How are we going to do better for the people who are not housed?
Well, it has to start somewhere. It has to start somewhere. And I think that if we continue to ignore the homeless population, they're just going to grow. Unfortunately, I think we're in an economic climate where there's less likelihood that people of color will own their homes. They will be renting. That means they'll be even more vulnerable in our communities, because if the owners of those homes decides to increase the rent or whatever, then they can, disrupt the lives of the people renting. So we've got to deal with the realities of what's going on in our communities and try to be ready for them instead of reacting after they have happened. And
Dr. Simon, you deal with so many different vectors of health in the public health domain. Another pandemic going on is violence using guns among youth, up 30% in 1 year now. And the leading cause of death for people under 19. Is that anything that we have any hope of dealing with? That seems to have just gotten out of control at the same time that we're facing homelessness out of control and COVID. What can we do about the gun violence that's going on?
Yeah, it's seemingly an intractable problem, but it shouldn't be. It again has been very much politicized over the last 30 years, increasingly so, and there just seems to be a stalemate, certainly at the federal level. I think California has been a leader in establishing firearm control policies, as has the county and the city of Los Angeles. And we were moving in a very positive direction on the violence front prior to the pandemic. We had seen some dramatic reductions in firearm and other related violence across the county. Certainly not enough, it's far too high, but we were moving in the right direction. And I think, unfortunately, the pandemic has reversed that. We don't understand all the factors, but I think the chronic stress of living through a pandemic, the emotional toll has likely contributed. The financial, the economic hardships that people have experienced during the pandemic, all of those have contributed. I would just like, though, to make a general statement. It's really interesting. You brought up the issue of housing. I think Dr. Wyatt brought up the issue of home ownership. And who would have thought that home ownership could relate to health? I mean, we think about health in the context of health care, and we think of it in the context of health behaviors. But I think it's really important for all of us to understand that health is impacted by many, many things across our society. And home ownership is an incredible immunizer, if you will, against adverse health outcomes. Anything we can do on the policy front to encourage home ownership and stability in housing is so very, very important.
How worried are we as advocates that a new variant is going to come down the road? We have all these problems that we haven't gotten our arms around, and there might be marching toward us something else that we don't even know about yet. Are we worried about that, Dr. Carlisle?
Well, ever since I was a medical student, or even before, I've been aware of the possibility of global pandemics in the infectious disease realm and others. I think every doctor knows about this possibility, especially every doctor who's involved in the direct care of patients with infectious diseases. There are other pandemics out there. We started out the conversation talking about AIDS and HIV. We certainly in the world should be talking about things like malaria and tuberculosis. I mean, these are major killers around the world. But there are other things as well. The reality is there's always the potential for a new pandemic. The question is, how prepared are we going to be to respond to it? And I think that we were not sufficiently prepared for the COVID-19 pandemic. When I was in state government, we were reeling from the SARS epidemic outbreak of the early 2000s. We had mobile field hospitals. We had ventilators standing by. We had stocks of face masks and things like that. Those things kind of disappeared prior to the advent of COVID-19. We were probably more prepared right after the SARS outbreak in the early 2000s to deal with the COVID-19 pandemic than we were when COVID-19 actually hit us.
I agree. I think that mobile units used to be more frequently used. I think that with COVID, of course, every kind of contact with people was discouraged, but those are really very effective ways of reaching people who won't come into clinics, who don't feel comfortable with a health provider, but who with community stakeholders could go out into communities and hold meetings and have potlucks, all the things that I'm talking about, because we have to break down Los Angeles. It's such a huge place, as Dr. Simon has said. We have to find ways of reaching people and making them know us and know our families. And one of the things that I'm so grateful for my parents doing is that they taught in Compton and Watts and Centennial and Jordan High. And many people who they taught still remember them and come up to me and tell me about how my parents taught them. That's the greatest gift they could have ever given me, because I'm committed to doing community-based research, because that's credibility. I don't have to explain where I'm from. I can say that my parents made a commitment long ago before I knew how important it was to connect to people like me. And they taught me that by the way they lived their lives. And even when we moved, they never left those schools. So I think that we need a way of, and I remember growing up, my parents used to say the first thing that a parent will ask you is, if you make a friend and you bring them home, who are your people? It's not just about you, it's your history, it's your commitment that makes people comfortable with you being the stakeholder and the leader in your community to say, we haven't been treated well in the past when it comes to health and mental health, but we can do better. And the first thing we need to do is to let people know that if we're comfortable, we're going to improve our health. We're going to demonstrate it is important. The Tuskegee experiment was not done forever. It shows that we weren't well, we weren't treated well, and that people need to do better. It's only an example of the past. What's our example today? We've got to get tested, we've got to get vaccinated, and we need to have healthy communities that relate and protect each other.
You've worked on the ground for many years, and Dr. Simon, you've been leading efforts in the Department of Health. Dr. Carlisle is leading our health providers of the future. We have a new mayor coming in. What can the new mayor do to address vaccination and the absence of vaccination in our population here in the city? Is there a role for government leaders to step up and help what the three of you are doing to attack this issue? What do you say, Dr. Simon?
Well, I would say very much so, and not just about vaccination, but our entire, broad approach to addressing the pandemic and addressing health overall. Many cities don't really see their role in health. They don't operate hospitals or clinics. They don't have their own health departments, with the exception of Long Beach and Pasadena. So historically, they haven't really viewed themselves as being sort of active participants in trying to improve community health. But we turned the tide a bit over the past several decades in getting them interested, for example, in tobacco control policies or in efforts to increase physical activity by creating more recreational space, creating healthier food retail to try to help combat the obesity and diabetes problems. And I think with COVID now, we've had pretty good engagement from most, if not all, cities across the county. And I think the elected officials have a really important role. But again, they can't be the only ones. In fact, in many cases, they may not be the best speakers. They, as I mentioned earlier, not everyone, fully trusts government. And I think, very importantly, not only being spokespersons, but a mayor and city council members have to do everything in their power to empower community organizations. Because again, those are, I think, the trusted messengers, as Dr. Wyatt said, really working block by block, going deep into communities, get everybody to appreciate their role in improving community health and advocating for policies that support health and well-being.
Well, I want to thank each of you so much for being with us today. This conversation will continue. We have in the chat a message from Dr. Jerry Abraham saying that testing is so important, and we all need to be helping to get that message out. Judith Haddad from our staff here points out that Kamala Harris has just reported that she's COVID positive.
Oh.
So it hits high and low and very wide. And we're grateful for all of the advocacy of the three of you, and we need many more advocates. So I hope the people who are listening today will join the battle and take the information that these three experts have shared to engage the community in continuing the fight. It's been a great discussion, and we will continue, not next month, but the month after, to have further conversation about where we are and what we need to be doing as a community. Until then, I ask you all to stay safe, follow the discussions that are going on everywhere, and we're going to survive this. We're going to dedicate ourselves to surviving this siege. Thank you all.
Thanks, Sylvia.
Thank you.
Thank you so much.
All
Okay.
right. Have a good evening.
Bye-bye, everyone.
Bye-bye.